ahead, turn on our recording again, and we can go ahead and start. So we're so honored today to have Gaurav Chattree joining us. He did his medical school at UT Southwestern in Dallas, and they have a great medical school there. And he did his residency in neurology here at Stanford, and he's just about midway through the first year of a 2-year movement disorder fellowship at Stanford. And as you know, movement disorder fellowship or movement disorder physician is a sort of physician that we always recommend people with Parkinson's or other movement disorders like multiple system atrophy. I see one of our attendees has multiple system atrophy. So that's the movement disorder physician is the sort of specialist that everybody on this call should be seeing, or their loved one should be seeing in the case that they're a caregiver. And Dr. Chattree, in fact, proposed this topic to speak about today at our support group. He said he's very excited about some developments, some things that are happening in the pipeline. So he wanted to talk to us today, provide an update on Parkinson's disease treatment and medication. So take it away, Dr. Chattree.
All right. Thanks, Robin, for the introduction, and thanks everyone for having me here. So yeah, as Robin mentioned, I'm a clinical fellow in the Stanford Movement Disorders Department. And then I'm also a research fellow in one of the labs on campus, studying the neural mechanisms of movements and movement disorders. So yeah, as Robin said, I wanted to give some updates on developments of treatments in Parkinson's disease. I think there are some exciting things to be looking forward to in 2022. And so I figured, I'd give everyone an update. So a little bit of background. So in Parkinson's disease, there are 2 types of treatments. So there are disease-modifying therapies. So these are therapies that slow or halt the progression of the disease itself, meaning that, in Parkinson's disease, over time, more neurons start to have dysfunction or start to die, and then these therapies are designed to slow or halt that decline. Symptomatic therapies, on the other hand, they improve or restore some function for the patient that may be impaired from Parkinson's disease, but they don't actually stop the decline. So all treatments currently in Parkinson's disease are symptomatic therapies. So levodopa, deep brain stimulation, these are designed at restoring function, and they work really well. But one of the things the community is really hoping for is a disease-modifying therapy that can slow down disease progression. So I'm going to focus on that first. So one thing to know is that there are a lot of companies and a lot of labs all working on disease-modifying approaches. I was reading some articles at the beginning of this year, and there's, I think, over 100 different small companies all working on some product or drug at some stage in development. Most of it is in the early stages, either in the preclinical or the phase 1 stage, where they're just testing it on a few patients just to see if it's safe. But there's a lot of exciting approaches, I think. And so, there's too many for me to talk about right now, but I wanted to focus on 3 things that we should be aware of. So one of these approaches is targeting the GLP-1R receptor. You don't need to know, exactly the specific, details here, but this is a drug that's actually already used. And it's been used for 10, 15 years, and it's used to treat diabetes. And actually, it also works for obesity and was recently approved for that. And what it does is it stimulates the pancreas to release more insulin. And there's a little bit of interesting backstory here it was originally isolated from the venom of the Gila monster in 1992 by Dr. John Eng. So what was happening is there were some patients coming in, they were being bit either by the Gila monster, or actually they were being bit by a scorpion, and they were becoming hypoglycemic or having low blood sugar. So Dr. Eng decided to study the venom. He found out what was causing that hypoglycemia and then isolated that drug, and that's how it got approved. And so you may ask, okay, this is a diabetes drugs, what does it have to do with Parkinson's? And so there are some labs around the world, what they do is that whenever a drug gets approved for some other reason, for diabetes or for hypertension or high cholesterol, they just test to check, does it also work on Parkinson's disease? And there are labs that do the same thing for Alzheimer's. They just check, this is a new drug that's been approved. Does it also happen to work for Alzheimer's disease? And so this one was tried, and it happened to show benefit in animal models. So it showed benefit in the animal models. And so they went to a phase 1, which was just a small group of patients. And in phase 1, they also saw a good signal. There seemed to be some improvement in symptoms, and it was safe. And so then they did a phase 2 trial. So phase 2 trial is a more rigorous trial. It has to be, you have to discuss with the FDA how you're going to set up the trial, and that it has more patients. So this was published and completed in 2017. So basically 32 patients received the drug, the GLP-1R drug, xenotide, and 30 patients received placebo. And they gave them these for 48 weeks, almost a year. And then there was a 12-week washout period to see what happens once the drug is stopped. So the first thing I think everyone would be wondering is, well, is this causing the patients to become hypoglycemic? Are there too many side effects? And in this case, actually, it wasn't. I think that the dosage is set up such that it's not causing hypoglycemia. It's given once a week. And the one side effect that it did have was it did lead to mild weight loss, but it wasn't anything serious. No patients really had to be stopped for that. And then there were some injection site reactions because you have to inject it into the skin, into the subcutaneous tissue. But those, again, were not major. And so the main information from this trial is seen in this graph here. So you have patients that receive the drug in blue, and you have patients receiving placebo in red. And what you're seeing is the change in the UPDRS scale. So that is a scale that we do in the clinic when we have you, do the finger tapping and hand open close and all those, movements that we have you do. We're grading the movements, the speed of the movements, how well they're being performed. And it's a score that we use to judge the degree of Parkinsonism or Parkinson's disease. And so you can see the placebo group, over time, their UPDRS score went up gradually, which is what we would expect because Parkinson's disease is a progressive disease. But in blue, you have the xenotide group that not only had an initial improvement in the UPDRS scale, but they were not worsening over time either. So in the washout period, when xenotide was removed, there was initially, some going back to the baseline, but they weren't worse than baseline, like in the placebo group. And so that was suggesting that xenotide may not only be giving a boost to improving the UPDRS score, but also holding that UPDRS score steady and helping potentially reduce the rate of decline of the disease. So I think this is a very exciting chart. And so here's just a follow-up chart they did. So they also looked at DAT scans in the patient. So you may have heard of these scans. They basically look to see, they give a frame of or some insight into how many dopamine cells are left in the patient. So they use this scan to show that the xenotide patients, the amount of dopamine cells they had left changed less than the patients that were receiving placebo. So that's another good marker. for potential disease-modifying benefit of this drug. So, of course, many people are excited about this. And so what's next? There's a phase 3 trial that's happening in the UK right now. It's 200 patients. Each patient will be followed for approximately 2 years, and we will hear the results in 2024. This is really the definitive trial in the sense that if this drug is going to be approved by the FDA and the European agencies, it will have to pass this phase 3 trial. But in the interim, many different groups have decided, well, let's do more phase 2 trials. Let's give more patients the drug, access to the drug, and we can learn more while we're waiting for the phase 3. So the UCs are all participating in this. They're all participating and recruiting. So if you're interested, as Robin mentioned, these slides will be online. And so I provided a link here about how to show your interest in participating in the trial. So this will be a phase 2 trial. You'll be followed for 9 months, and we'll know the results probably by the end of 2023. But the reason I said that 2022 is exciting is because many other phase 2 trials will be completed in 2022. So around 5 of them actually, and that's all across the world. And so we have one positive phase 2 trial, but if 5 trials are showing similar results, even though they're phase 2, that would give a lot of strength to the idea that this drug is having benefit. You could say, oh, one trial, there's just some random chance that happened. It wasn't a true effect. But if 5 phase 2 trials are positive, then it's very unlikely that it's just random. So that's what's exciting about 2022 is that hopefully by the end of this year, we'll hear about all these phase 2 trials and we'll get a lot more insight into whether this drug is effective. So we're all crossing our fingers, and we've all got our eyes on these trials. Okay, so that was one approach that I mentioned. Oh, we have a question here. Oh, thanks for posting that, Robin. Yeah. And then, so that is one approach that I mentioned. That honestly, how did anyone find out that drug works? It's a little bit of trial and error. And so it's nice that people tried that and it seems to have effect. The next 2 approaches I'm going to talk about are designed based on what we understand about the disease. And so the hypothesis in Parkinson's disease is that there's this alpha-synuclein protein that's in our brain. Something triggers it to misfold. There's many different things that are associated with that triggering of misfolding. And then once it misfolds, it starts to accumulate. The misfolded protein causes other, nearby proteins to misfold, and then that causes more and more of this alpha-synuclein to pile up, and that propagates throughout the brain, causing neuron dysfunction and neuron death. So then the goal would be, well, let's stop alpha-synuclein misfolding, and let's stop the propagation of alpha-synuclein spreading throughout the brain. So there's many strategies that have been thought about here. So let's provide some antibodies against alpha-synuclein so that it attacks the alpha-synuclein. Let's have the body generate its own antibodies to alpha-synuclein, kind of like an alpha-synuclein vaccine. Maybe we can design a small molecule that interferes with alpha-synuclein, or one of the newer approaches is let's put in another protein that breaks down alpha-synuclein. So all of these approaches are in some stage of development right now. The ones that you may hear about, okay. So, sorry, one other comment though, is that these have been tried in patients already over the last few years, and unfortunately the results have been mostly negative. And so, we have to take a step back and say, like, this is our hypothesis, and why isn't this approach working? And my opinion, and many other physicians' opinion, is that it is possible that you have to give people these drugs very early. If there's already a lot of misfolded alpha-synuclein in the brain, it may have triggered all sorts of other processes in the brain, triggered a cascade of neurodegeneration, and the cascade is already in motion. And so removing the alpha-synuclein may be too late if it's given at a certain stage in disease. This seems to possibly be what's happening in Alzheimer's drugs. There's a similar drug, and the idea is that maybe it's being given too late. So I think that studies will need to eventually be done in patients who do not have Parkinson's disease quite yet, but they either have a very high risk of developing it due to genetics, or we actually have some new markers that give us a sense of how likely someone is to develop Parkinson's disease. So this was recently approved by the FDA. There's a company in San Diego, and then also the professor who works on it is out of UT Houston. And so that basically, it takes spinal fluid from the patient, and it can see small amounts of misfolded alpha-synuclein. And so it can catch it probably in patients that are not yet showing symptoms, but are starting to have some misfolded protein. So I think the strategy may be, to take a large group of people, check their spinal fluid, see if they're developing this misfolded alpha-synuclein, and then give them the drug before they develop symptoms. There is a hurdle, and that is, you'd have to convince the FDA that it's worth giving patients who don't have any symptoms now an experimental drug that may have side effects. You have to be really confident that these patients will develop Parkinson's disease with a high probability, and we think that our drug has a very low chance of causing side effects. So that is the hurdle there, but I think it's a doable thing. And so what's next is that there is a trial right now that's phase 1. So this is actually an alpha-synuclein vaccine that's similar to like what you may have heard about the COVID vaccine. Basically, you get the body to generate its own antibodies against alpha-synuclein to try and remove it. There's a much larger study happening with this drug, Prasanisimab. That's you actually just create the antibody outside somewhere else, and then you just put it into the blood. So this will have almost 600 patients, and we'll know by 2024. And then there's many other phase 1 trials in this category that are already underway, or they will be initiated soon.
And Dr. Chattree, just a question here. Are any of these studies being done in prodromal patients, or no, they're all in those?
No, right now they're not being done in prodromal.
Okay, patients. All right.
Yeah. But that would be the next step. So I think what's going to happen is first these trials will be run, and that will show the FDA the relative safety of these. And so if there's not any major side effects, then I think the FDA will be much more convinced to giving these patients in prodromal, giving this drug in prodromal patients. Yeah. Okay, so then another approach, the changing gears here, is that there's a protein called, or there's a gene and protein called LRRK2, LRRK2. You may have heard about this. It's one of the most common genes associated with Parkinson's disease. What happens in this situation is that this protein is mutated, so it doesn't have its normal properties, and it seems to be hyperactive. It's functioning too much. It's doing too much of its job. And so how exactly that leads to Parkinson's disease is unclear. There's lots of different hypotheses about, changes it may be making to the cell. But it does very clearly seem to be an association that if this protein is hyperactive, then it's causing some sort of dysfunction in the cell, and that can lead to Parkinson's disease. So what's the goal? Well, let's design a way to slow down this LRRK2 enzyme or protein. It's hyperactive. Let's try to make it either normal function or hypoactive. So the main company working on this is Denali Therapeutics. So they did a phase 1 recently, and it was safe. They didn't check to see if it was effective. They mainly were just checking to see if it was safe, and it was. And so now they are beginning soon enrollment of clinical trials for this LRRK2 inhibitors. And they're actually doing two separate trials. So the first trial will be in patients that are known to have a mutation in LRRK2. So you get your genes tested, you see that you have this LRRK2 mutation, and so you'll be in one trial. If you don't have the mutation, then there's a separate trial for that. And Denali's reasoning for why they're going to do it in patients that don't have LRRK2 mutations is that there is some preliminary data that even patients that don't have the mutation, LRRK2 is still hyperactive in Parkinson's disease. So that's why even if you don't have the mutation, it seems that LRRK2 might still be hyperactive. And so they want to test that and target that. The other company that's working on this is out of San Diego, Ionis Pharmaceuticals, and they're working on a genetic way to fix the LRRK2 enzyme. And so they are in a phase 1 right now. So that's a small amount of patients, and it's mainly going to just check safety, and we'll know by 2023. But yeah, if you are interested in this trial, or let's say you know you have a LRRK2 mutation, you can see it on 23andMe. Actually, 23andMe will show that. Then you may want to check out this website, engageparkinsons.com. So those are the main approaches that I think we should know about for disease-modifying approaches. As I mentioned, there's probably 100 different things that are being done here, but I think these are the most promising. And that's why I wanted to just let everyone know about them. And so now I'm going to shift gears again, this time to symptomatic therapies. So these are therapies that do restore function temporarily. They work usually well. They last for many years. So just briefly, I'll say in terms of drugs that have been approved, actually they're just all new versions of old drugs. So they're useful in some special cases, but for most situations, they don't really change treatment. So it's just reformulations by pharmaceutical companies. But there are new interventional approaches that are going on. So interventional, I mean that there's some sort of procedure being done to the patient to either, like deep brain stimulation would be considered interventional. It's a procedure that's being done. And so I'm going to just go through those. So one that's being explored, and actually it's already been approved as of last year, is focused ultrasound beams into the brain to affect the subthalamic nucleus. This is a very specific part of the brain. It's involved in Parkinson's disease. And the idea is to give high energy ultrasonic waves to this area to damage it, to kind of essentially destroy it. And we have a lot of evidence over the years that destroying this region of the brain improves motor symptoms. And actually deep brain stimulation also goes into this nucleus, and deep brain stimulation may in a way be sort of acting similarly to a lesion, though that hasn't been proven yet. So the trial was done a year or two ago. So it was 40 patients. 27 got the actual ultrasound, 13 got some sort of sham. So it was like some sort of vibrations that they were getting, but they weren't actually getting the ultrasound beam. So you can see the chart on the right that patients who got the treatment had a significant improvement in their UPDRS score. So that's around 8.1. So again, the UPDRS is a marker. It's what we use in the clinic to say how you're doing motor-wise, how slow are you moving. And so these patients had an improvement. They could move faster, or they had less tremor. And it held up for a year. It didn't reverse. So you can see at month 12, they still had this improvement. One thing to know here is that this is only one side. So let's say your right side is the side that's more affected. then they would do really focus this to affect your right side only. They weren't doing it on both sides of the brain, just one side of the brain. So the one problem, though, is that when you look at some of the side effect profile, there were 2 patients, 2 out of 27 patients that received the treatment, but at 1 year they had weakness in their arm. So what probably happened here is that they damaged more of the brain than they had intended to. And that's not, insignificant. And 2 out of 27 is a decent amount of patients, almost 7%. And a reminder, this is only being done on one side. So if you're doing it on both sides, the chance of developing this weakness, would be higher. And so that is one major caveat here. So what's going to happen next, and this is already happening, centers around the world and in the United States are using this focus ultrasound technique, and they're trying to get better and better at targeting the correct site and the correct site only to minimize side effects and to not get weakness. We already heard anecdotally from one of the centers in Maryland that they're not getting any weakness in their patients, and they're doing it on a regular basis. And I think what's happening is that as people get more experience with the technology, they'll learn to use it better and to improve the side effect profile. The other thing that's happening next is that there's a trial. It's going to be small, it's just 10 patients, to see if this focus ultrasound can be done on both sides of the brain to affect both sides of the body. 10 patients, we'll probably know by the end of this year. So my thoughts on this is that right now, the side effect profile, I think, needs to be worked out. And I think in most cases, I don't think that this is the treatment we should jump to. There are certain cases where it's useful, and that is patients who can't really handle medications. It's giving them too many side effects, and they can't get deep brain stimulation for some reason. Either the most common reasons that someone can't get deep brain stimulation is that they've crossed the age limit, which is that we don't typically do deep brain stimulation in patients above the age of 80, but we will do focus ultrasound in them. So that is an area where I think this could, it certainly would have a use. And then I think the other big advantage, of course, is that this is a one and done procedure. You don't then have to have hardware in your brain. So maybe in the future, as the side effect profile improves, then it could be a good alternative to deep brain stimulation. I don't think we're there yet, and it may not be worth taking that risk. Okay, this is one that you're almost certainly going to hear about in the news, and that is stem cells for Parkinson's disease. And I think whenever you hear something about stem cells, it's good to be just a little bit skeptical. And so the idea here is not that stem cells will be used to cure the disease or to, cause some or create lead to long-term improvement necessarily of like Parkinson's disease in general. It's not a disease-modifying approach. I'll just quickly say there, the reason we can't do that yet is because we can put neurons into the brain, but we can't get them to connect in the way that we want them to. So we are a long ways away from that. I think UC San Diego has recently had some exciting results on getting neurons to connect to the right areas, but we're still a ways away there. So what's being done here is that, in Parkinson's disease, you lose dopamine, and that's why you take levodopa to boost the dopamine to give you more dopamine. So what they're doing here is they're just putting dopamine cells, dopamine producing cells, into the parts that are affected by Parkinson's disease. So dopamine cells are dying, let's replace them. It's essentially like having a dopamine pump in your brain, like a continuous dopamine pump in your brain. So this was actually done in the 1980s, 1990s, And there were mixed effects. There were some patients that had really nice benefit. There were some that had no effect, but there was a large population of patients that actually got worse. And that was because it was too much dopamine, and that dopamine was causing dyskinesias. So that's why it was sort of halted in the 1980s, 1990s, because people were having these dyskinesias. And, there are medications to try and treat dyskinesias, but these were very severe dyskinesias. And so those medications weren't effective. So that's why these trials actually came to a halt in the 1980s, 1990s. What's the argument now for doing it again? So the people involved in this, what they're saying is that we've got better quality stem cells. We think we know how to control the amount of stem cells we're putting in better. We think we have safer and better surgical techniques. Let's try it again, see if we can help some patients. So this is being done all across the world: Australia, Japan, UK, China. It's all phase 1, so really early stage. One thing I've noticed, though, reading about these trials, is that they're typically doing it in late stage Parkinson's disease. And I would say the reasoning for that is this. Over time, when you have Parkinson's disease, you first get Parkinson's disease, you're giving yourself a certain amount of levodopa. Then you have to go up on the levodopa as the disease progresses. And then what happens is that levodopa might be too much. You're getting dyskinesias. So you have to get fitted into this narrow therapeutic window. And that therapeutic window becomes narrow over time. I think what they're doing here is putting it in advanced Parkinson's patients. So patients that maybe don't have as much life expectancy for the amount of dopamine they need to fluctuate. And so they're just going to put in a steady amount, and then that should, not change because they're advanced and they may pass away from other reasons. So I think it's gonna work, for these cases, because it is a dopamine pump. I think the technology is there, so it is a dopamine, boosting treatment. I just think, it's really only for these select cases. I think for someone who, is just getting the disease, it doesn't make sense, because you will need a very narrow amount of dopamine, and basically whatever they put in when they first put it in, the amount of dopamine you're getting, it may not be what you need later on. And so you'll have probably what we call runaway dyskinesias, or too many dyskinesias. So that's certainly the challenge here. I think, it's interesting. We'll probably learn a lot from these trials, and there are select cases where it will be useful. But it's just important to, I think, understand the full background here. The last thing I'm going to talk about is adaptive deep brain stimulation. So this is actually Dr. Bronte Stewart, who works at Stanford. She's our most senior clinician in the movement disorders department. This is her area of expertise, and she is actually the international PI. She's basically running the whole trial internationally to test this technology. And so what is it? You have deep brain stimulation, and that is giving some constant amount of stimulation to improve symptoms. But what if throughout the day and different situations, you really need different types of stimulation or different amounts of stimulation? Maybe there's one type of stimulation that's better for your walking, and then there's another type of stimulation that's better for you when you're eating to control your tremor. Can we design deep brain stimulation to automatically adjust to the situation that you're in, so that you have optimal deep brain stimulation throughout the day for the various activities that you're doing? So the idea is that it will read some signals from your brain. You may also be wearing a wristwatch or something on your foot. It will read some signals from there. So those are called kinematic signals. That will then feed into some program, and it will allow the deep brain stimulation to automatically adjust itself based on the signals that it's getting. The picture that I have here is, there may be someone who's starting to develop freezing of gait. So it will be detected by some of the sensors on the body, and then the deep brain stimulation can switch to a mode that is better for freezing of gait. It can quickly switch over to that mode. That's the idea. It's still in very early trials, so I can't speak too much about whether we're seeing benefit or not. But yeah, this is being run by Dr. Helen Bronte Stewart at Stanford. It's being done at multiple sites as well. UCSF is involved. And these are the name of the trials, the ADAPT-PD and the SPRING trials. And so if you're interested in some of these trials, you know, you're in a position where you're thinking about deep brain stimulation, I think you can, yeah, either contact Robin or contact me, and we can give you the information to be involved in this. I think particularly if you're having gait freezing, this SPRING trial is really focused on that. So yeah, you can just let us know if you're interested. So I want to give a summary of what I've talked about today. With regards to disease-modifying therapies, so therapies designed to slow or halt the progression of Parkinson's disease, I'm really excited for 2022 because we will have a lot of results from these GLP-1R agonists, and phase 2 looks promising. So let's cross our fingers that these trials are showing similar effects. And then, you know, we'll know by the end of this year. The other approaches I talked about, I think the science is really sound here. I think they're likely to work. It's just, it's going to take time, and they're still in the early stages. And then I talked about some symptomatic therapies. So focus ultrasound, useful in certain cases, stem cells, probably useful in certain cases, and then adaptive deep brain stimulation, probably also useful in certain cases. So we'll have to see. These are some of my sources. And then, yeah, I'm happy to take any questions that people may have.
Okay, Dr. Chattree, thank you very much. We have a couple questions that have come in, and let me ask one, which is, so if you are in advanced stages of Parkinson's disease, and
Yeah.
maybe you're not 80, but you know, you're mid 70s or something,
Yeah.
which of the, doesn't sound like you're a big fan of stem cells, but, and the trial number is very limited anyway. Would you perhaps look into the STN ultrasound, or which way would you go?
Yeah, I think if you're a candidate for deep brain stimulation, you should go with that first, because that's tried and true. And then there's going to be these adaptive techniques that will probably come out that could make deep brain stimulation even better. So we have the most experience with that. The side effect profile is the best. So if you're a candidate for that, I would go with that. If you're not a candidate for deep brain stimulation, then I think focus ultrasound could be a good option.
Okay. And how would you, and if you were a candidate for DBS, would you encourage people to explore the adaptive DBS approach?
I think so. I think it's worth trying because let's say you don't like the adaptive version, you can just turn it off, you know.
Oh.
So it's just an experiment. It's just it's a very easy thing to just switch on and off.
Oh, perfect.
Yeah,
That's
it'll
great.
just switch right back to standard DBS. Yeah.
Yeah. Okay. One of the chat questions, and by the way, anybody who has a question, just type it into the chat or type it into the Q&A box, and we can read it. Someone asks, are any other disease drugs used for Parkinson's disease? Example of diabetes drugs, or is it only certain conditions for off-label use?
Let's see. So the question is asking, are there other,
like, can you use it? Are there diabetes drugs that can be used also for Parkinson's disease? And would these only be off-label uses, or have some drugs been studied? I know you mentioned the Gila monster.
Yeah, exactly. Yeah. So I would say a lot of approved drugs, you know, have been checked to some degree, you know, to see if there's any benefit in Parkinson's disease. Really the ones that are standing out are these GLP-1R drugs. So it wasn't only just the phase 1, there was also a retrospective study that someone did where they looked at everyone who had Parkinson's disease and everyone that had diabetes. And so they were all on a variety of diabetes drugs. It seemed like the patients that were doing the best from a Parkinson's standpoint were on these GLP drugs. So yeah, right now, I think it's too early to start prescribing this off-label because we only have the one phase 2. But let's say by the end of this year, all 5 phase 2s are positive. Then I think people are going to want to prescribe it off-label. That's my sense, but we'll have to wait and see. Yeah.
Right. And what did you say were the side effects? I don't recall what side effects were for that.
It actually ended up being relatively minor because I think the dose was lower than in other situations. So there was a mild weight loss, but that can be overcome, but just by eating more, things like
Not
that.
necessarily everyone would want to overcome that.
Yeah, right. That could be a positive side effect.
That's right.
The other side effect was an injection site reaction, but again, really mild. You can just give some topical steroids or something to improve that. And those are really the two main side effects. Yeah.
And with that, the Gila monster drug,
Yeah.
sorry, I don't,
Sure.
xenotide, I think you said. Is that drug, I remember the chart that showed the UPDRS score, the placebo going up and then not placebo going down, which is what we'd want to see.
Yeah.
And so is it basically a treatment of motor symptoms in Parkinson's disease?
That's the thing we don't know yet. The thought is that it might be a treatment of motor symptoms. It might have some symptomatic benefit, but it might also have some slowing down of disease progression, because when you release the patient from the xenotide, this washout period, they're still not really different from their baseline. Whereas if they were progressing, then you may expect them to bounce back like up here. Yeah.
I see.
Yeah.
And is that that the left axis there, the is that a percent change or a change in points? It's an absolute change.
It's an absolute change in points.
Yeah, so I wouldn't call an absolute change of 1 point to be very significant after the washout, the 60-week, but certainly absolute change of 2.5 versus the placebo. That's quite a big difference there.
Yeah.
Yeah, that's interesting. And is there a theory as to why insulin would help with motor symptoms or any other symptoms of Parkinson's?
No, I would say there's like 30 different theories.
Okay.
So no one knows for sure. Yeah.
Okay. And is this common in research where we don't really know why things work, yet we proceed anyway?
Absolutely, very common. Very common.
Okay. All right. Okay, one of the other chat questions is, does the cause of Parkinson's disease matter in regard to the therapies? So you mentioned, for example, that LRRK2 inhibitor. You said that even if you didn't have the mutation, there's some thought that LRRK2 in anybody with Parkinson's disease is still hyperactive. Are any of these other therapies specific to the cause of Parkinson's disease?
Yeah, I think so. I think to some degree they are specific. So even for the LRRK2, you may hypothesize it's more likely to work in someone that has the mutation. And then in the alpha-synuclein one as well, there are actually some cases of Parkinson's disease where the amount of alpha-synuclein isn't that much, or it's not even really there. So the cause of Parkinson's disease is variable, is heterogeneous. And so I do think that plays into a role will play a role into whether these disease modifying drugs would be effective. Yeah.
Right. Okay. One of the other chat questions is, what about a non-invasive therapy like a vibrating glove? I'm sure you're
Oh,
familiar.
yeah. I didn't speak about that. So that trial is also going on at Stanford. It is a symptomatic therapy. The reason I didn't include that is that I think it's really early to say. I'm just not sure. But if you are interested in that, again, contact either me or Robin. So the idea there is that it's vibrating some nerves, I think, in your arm, and then that vibration is leading to some stimulation in the brain, and then that stimulation in the brain is leading to improvement. That is a potential. We'll see. I think it could possibly work. We just have to see.
Okay, somebody points out that a prior use of dopaminergic treatment or MAO-B inhibitors for more than 28 days excludes you from participating in xenotide, the Gila monster study.
Wow.
Yeah.
Okay.
Somebody really knows their stuff.
Oh, wow. Was that in the UCSF link?
I don't know. That's what somebody in the chat says. So
okay. I'll have to check on that.
yeah, we can check on that. Yeah.
Yeah, that would exclude a lot of people.
Yeah, it sure would. Let's see. Oh, somebody asked, and that must have been from the UCSF, and somebody asked, what are these drugs, the dopaminergic treatment or MAO?
Yeah, so prior use of dopaminergic treatment.
Maybe just go to the UCSF website. Yeah, and then we can put a button on that question.
Yeah. Let me check the link and let me get back to you on that. And then I saw there was another question about can someone who has DBS installed already switch to the adaptive element? It depends. If you have Medtronic, then potentially, yes.
And the reason is that the adaptive DBS study uses the Medtronic system, such that there's a possibility. Yeah. Okay, yeah, so the gentleman said, yeah, it's from the UCSF website. That's very interesting.
Wow, prior use of it.
So that would exclude a lot of people. So could you say what those drugs are so people?
Yeah. And I should also email them. But I mean, really, this is, eldopa or the dopamine agonist or rasagiline or Azilect, selegiline. So pretty much everything.
Right.
So
Cinemet, Stalevo.
Yeah. I guess what they are doing here. Oh wow, there's a specific
untreated PD.
Untreated part. The other trials are not necessarily like that. So the trial that I showed you with the chart, that is not untreated. That's not this. What you could be on treatment for this. I mean, all the patients were already on those drugs. So I guess for some reason the UCSF trial is untreated. I'm sorry, I didn't realize that.
Okay, well, thank you to Mark for pointing that out. Very, very useful. Okay, and Mark asks, is it an agonist or eldopa? Yes.
It's both.
But yeah, either of those would. Okay, are there any other questions? If you can type them into the Q&A box or the chat box. Thanks to everybody for your questions so far. It was interesting what you said about stem cell treatment. You don't seem very enthusiastic about it. And I remember for the studies a long time ago, I think the ones, back maybe in the 80s, they had done I'm sorry for, I think they were in Sweden. A lot of them were in Sweden. And the people who had participated in these studies, they had died, gone to autopsy. The families donated the loved one's brain because these are extremely precious brains to see what has happened in the brain. And they found that the Parkinson's disease basically returned and infected those same cells, the new cells that were implanted.
That's right. That's right. I had heard about that. Yeah.
Yeah, it's really, really remarkable.
Yeah.
That even new stem cells still got Parkinson's disease. So, okay, one more question. Oh, restate of my first question. Oh, well, you can see it.
Yeah, I see it. I see it, Diane. As of right now, there are none that are really at the stage of like xenotide, but people are constantly looking at these type of things. Whenever a new drug gets approved, people are looking for signals like, okay, are patients on this drug less likely to get Parkinson's disease? Is it showing some effect in animal models? So it is something that people are always looking at. So we may see something else map on, other diseases. But right now, really, the big one is this GLP diabetes drug.
Right. And are there other diseases besides diabetes that we consider? I guess people are always considering all drugs for repurposing.
Yeah, exactly. So for example, like with COVID, basically everyone was like, let's analyze every drug that we have to see if any of them are effective and can be repurposed. So that was happening.
Yeah. And so some unnamed researchers out there are systematically going through drug by drug, and I guess they take a little petri dish of alpha-synuclein and see what happens when you stick that chemical in.
Right. I think there's two separate approaches, and that's the other thing. The approach should get better and better over time. So I think initially, maybe it's some petri dish, but then it'll go into animals, so like mice or rats. But I think the most actually interesting thing is that what we're going to probably see in the next few years is that you take a patient that has Parkinson's disease, you take their cells, like maybe their skin cells or something, you can actually convert them using some compounds to dopamine cells. So it's almost like you're getting the patient's own dopamine cells. That is really cool. And so then you might imagine that may be even better than an animal model because it's like a human cell and it's a human that has Parkinson's disease. It's their cell. So that would be another good testing site. And that's already happening. People are working on using that.
Whatever happened to the idea of giving people one of those nicotine patches to see if that helped with Parkinson's symptoms at all?
I'm not sure. I would have to look into that. I haven't heard about that one. Yeah.
All right. That was kind of a rage a while back, and then never heard anything about it. Let's see. And one other thing you said at the beginning caught my eye, caught my ears, caught my attention, was you're talking about the alpha-synuclein and disease-modifying therapies, a vaccine, for example. And you described it as being the theory of Parkinson's disease. As to the theory is that it's caused by alpha-synuclein. Don't we know that yet, that it's caused by alpha-synuclein misfolding, or is it still a theory?
There's a lot of people that will debate with you.
Oh, really?
Yeah.
Oh, gosh.
Because they will say like, oh, if that's the case, then why did getting rid of alpha-synuclein not fix it? So there's actually one big neurologist that's he's like constantly posting articles about why he thinks the alpha-synuclein hypothesis is not true. So my personal belief is that it's true, and the reason I say that is the genetics. It's like if you have a mutation in alpha-synuclein, you make more alpha-synuclein, and you're likely to get Parkinson's disease. It's hard to argue that that's not a causative reason for Parkinson's disease, so that's my own thought, but there are people who will debate with you. Yeah.
Right. Okay. Interesting. Somebody asked, are doctors prohibited from off-label prescriptions? I think they're probably thinking of the xenotide.
Sure. No, we're not. But it's always a risk-benefit discussion between the doctor and the patient. And, the more evidence like for me, example, one phase 2 trial, it's too risky. It's only 30 patients. Well, it's risky in the sense that it's not really that dangerous, but I'm not sure, and so I don't think most people will do that off-label. But by the end of this year, if multiple trials are showing positive, I think that people may do it off-label.
Mm-hmm.
But we are not prohibited. But it may, we don't know if we can get insurance approval, would probably be the big thing. So for off-label, there's no insurance guidance.
Right, of course. Yeah. And do you know how much xenotide costs?
I don't.
Okay. Is it a brand name drug, no generic available?
I'm actually not sure about that.
Okay. All right. Well, if the person who's chatting with us about xenotide, if you find out, let me know and I'll share the information with our group. And again, if anybody has any more questions, please type them into the chat or the Q&A box. Let's see, I wanted to ask, so currently DBS is done either in the subthalamic nucleus, the STN, which you mentioned as the target for the ultrasound, STN ultrasound, or it's done in the globus pallidus, GPI. Why is the ultrasound done in the STN? Could it also be done in the GPI?
It could also be done in the GPI. And I think people are working on that too. Actually, in the olden day, I use the word olden, but probably in the very initial stages of intervention, like interventional approaches for Parkinson's disease, the initial approach was pallidotomy. So you would directly, it wasn't by ultrasound, you would put something into the globus pallidus and damage it. The problem is that you would cause too much damage, and so there are too many side effects.
Okay, very good. Let's see, I think I'm out of questions. If anybody has any more questions, yeah, thank you, Mark. So thank the speaker for answering all the questions. Thanks very much for everybody for asking the questions, and appreciate it. And again, we will post the slides. Dr. Chattree's already given me the slides, so I'll post the slides and a recording to our group's webpage. Probably tomorrow, but certainly by the end of the week. And we thank you so much. And Dr. Chattree is going to be speaking again on our June meeting. Let's see the date for that. The second Wednesday of June is Wednesday, June 8th at our usual time, 2:30. And he's going to be talking about anxiety, depression, and apathy, I believe are the 3 mood-related topics. So that was what I initially wanted him to talk about. And he said, no, I would really like to tell you about these exciting things going on. So we appreciate that. And it's always good to have a speaker who's excited about their own topic. So that's a good thing. So we thank everybody for attending, and we'll see you next time. Thanks very much, Dr. Chattree. Appreciate it.
Thanks, everyone.
Bye-bye.